thank the Iraqi Society of Orthodontics for their kind invitation. I'm going to start sharing my screen. Namely, I would like to thank Professor Al-Hwaizi. I hope I pronounced your name right, and also the moderators for this session, Professor Aldabah and Professor Saloom, and also Professor Nahid. So thank you very much for receiving me today here in this event, and I hope I can contribute to the Iraqi Society or Iraqi Orthodontic Society. I met Professor Akram in Jeddah, I believe a couple of years ago, maybe last year, and it was a great pleasure to meet him. And I believe that this invitation came due to our connaissance in Jeddah. The idea here today is to talk to you about the gummy smile. I would kindly ask you all to respect the presentation, most especially the intellectual property of this presentation and the privacy of the patients that will be presented herein. I know that today it's very easy for us to record or to take pictures of a screen. You can feel free to take pictures of the didactical material, but please do not publish or post pictures with the patients. I would really like you to kindly respect this demand. And Professor Akram has very kindly presented myself. I know it's a lot, but really all you have to remember is I'm Flavia from Brazil, and hopefully we will be meeting you here in Rio de Janeiro in 2025. And the idea of talking to you about the gummy smile is really to point out in specific aspects that we have to look before we leap into the correction of this problem. And I began my interest on the gummy smile because I was invited to write a book chapter together with two prominent periodontologists in Brazil, and they wanted us to talk about the orthodontic vision of the gummy smile. And that's really what I want to point out. Where or in which cases can we treat the gummy smile only orthodontically? So the gummy smile already has a semantic associated to the gums, but it is described as an excessive gingival display during smile. And that's quite a very broad description, since what is excessive to the population? When does a gummy smile begin to have a significant impact on aesthetics? And this paper was the first, I would say, computer graphic manipulated paper in orthodontic history, published by Complicates Jr. and collaborators in 1999. And what he did was he modified by using computer programs the exposure of the gingiva and many other different aesthetics aspects of the smile. And these pictures had to receive scores from orthodontists, dentists, and lay people. And the gummy smile started to call attention when it was greater than 2 millimeters for all these evaluators. But not only the exposure of the gums is an important factor when we regard smile. The other factor that is really of great importance is the amount of incisor display. So this study, performed by Brazilian researchers and published in 2013, did the same sort of modification with the gum exposure, but also with the incisor exposure. And the less you saw incisors, upper incisors in the smile, the worst were the scores. The most pleasant smile was this one, where you could see some of the red area or the gummy area, but also the full length of the upper incisors. So these are two things that we have to keep in mind. Showing some of what we call the red aesthetics or the gingiva is important in making the smile appear more aesthetic, but also showing the full length of the upper incisors. We also associate gummy smiles to an aesthetic problem. I may say that it is probably the only problem that we have in orthodontics that only impairs the visual aspect, because all the other aspects such as crowding or an open bite or a deep bite, all of these will also impair function or at least oral hygiene. But the gummy smile only has an aesthetic impact. But looking at people with gummy smiles, comparing them with people that do not have gummy smiles or excessive gingival exposure regarding quality of life, have demonstrated that individuals with gummy smiles had higher scores on quality of life questionnaires such as the OHIP 14 with comparisons to the control. Their limitations included the functional aspect, the psychological aspect, and the social aspect. So it's really not just an aesthetic issue, but it's an issue that will affect patients psychologically and will have an impact on their quality of life. The interesting thing about the gummy smile is it is associated to the gums. So patients most naturally do approach or evaluate the gummy smile with a periodontologist. And most of the publications on gummy smiles come from periodontology. But despite the semantics, it is a multifactorial problem due to the anatomic and morphofunctional characteristics of the smile. So when we think about the smile, we have many tissues involved in this anatomic aspect. We have the teeth, we have a muscular tissue, which are the lips, we have a bony tissue, which is the alveolar bone, and we also have the gums or the gingiva, which will cover this alveolar bone and even the teeth. So we will have 4 different factors which can be approached in the correction of the gummy smile. And if you want to have a look at what is really necessary for the adequate anatomy of the smile, this is an interesting paper published by Dr. Kamara in the Dental Press Journal of Orthodontics in 2010. I'm going to take my image from the QR code so that you can take a picture and you'll be able to download this paper for free in English and look at the necessary aesthetic needs for a good smile and how you can point this out easily or communicate this easier with your patient. Another issue with the smile, it is not an aesthetic aspect or characteristic or feature. The smile is dynamic, changing from a posed smile to a spontaneous smile. And the way we can see the difference from a posed to a spontaneous smile is the amount of contraction of the eyes. So usually patients with a gummy smile have the ability to control the amount of muscular contraction that they will perform during smile and can hide the gummy smile, most especially during our clinical examination. So be aware that when you're diagnosing patients with a gummy smile, you need to evaluate the spontaneous smile, and you can see this by the contraction of the periocular musculature. And smiles have different types. Rubin in 1974 classified the smile in 3 different morphologies. The Mona Lisa smile, where you will have more contraction of the muscles that elevate the corners of the mouth. You have the canine smile, where these muscles that elevate the midsection of the upper lip have more activity. And you have the complex smile, the smile that shows all or exposes all of the teeth with a large contraction of all the oral muscles, all the muscles involved in the contraction of the lips. And because we have different smiles, obviously, this frame of the smile can be different from each patient. The gummy smile can be classified as a total smile, gummy smile, where you will have gummy exposure from the posterior all the way to the other side in the posterior segment of the mouth. You can have an anterior gummy smile on where the excessive gingival display will be restricted to the anterior area, or you can have a posterior gummy smile where the excessive gingival display will be in the posterior region. And you can still have an asymmetric gummy smile due to the inclination of the occlusal plane, as you can see in this asymmetric patient. So needs will be different from each patient to patient. The fact is that because the smile demands or includes so many different body tissues, it will have different etiological factors. It can be skeletal by vertical maxillary excess. It can be only dental by the extrusion and or protrusion of the upper incisors. It can be gingival due to gingival hyperplasia, and it can be muscular due to the lip length or the amount of muscular contraction of the lips. Let's have a look at each one of these etiological factors. The vertical maxillary excess, which would be the skeletal etiological factor, happens when the patient has a disproportion on the length of the face with an increased lower facial height, and you have an excessive growth of the upper alveolar process. And one of the ways of diagnosing this is when the lip commissures are very far away from the occlusal plane, as you can see in this last photograph right here. You see the commissures are far away from the occlusal plane. And in these patients, usually you will have associated to it a very increased lower facial height. The upper incisors can be extruded, such as this situation where you have a gummy smile, but you can clearly see that these lower incisors are below the lower lip. You can see this easier in the radiograph where you have 5 millimeters of incisor exposure. You can see here on the occlusal plane that it descends in the anterior region, associated generally with a deep bite. The upper incisor protrusion will be associated to a gummy smile due to the muscular contraction. So patients with severe upper protrusion have sort of a ramp on the upper arch, which will encroach the upper lip. So you can see here the amount of protrusion of the upper incisors, and it's as if the upper lip would hide behind this severe amount of protrusion and expose a lot of gingiva. The gingival hyperplasia is diagnosed through probing, and it is obviously in cases where you have much more dental crown below the free gingiva or margin, as you can see in this probing situation. Lip length is the amount of lip that you have in the central area, where you can measure this by the perpendicular lines to the base of the nose and the commissures and the central area of the philtrum. So this would be a short lip and this would be a normal lip. And lip mobility, which is characterized by the amount of contraction of the upper lip, as you can see in this video. So the big problem with these etiological factors is that it's not always they come on their own. They can come together. And the other issue is that not always you will be able to approach the etiological factor to correct the gummy smile, because you have to pay attention to the facial proportions, you have to pay attention to the smile aesthetics, and you have to pay attention to the vertical position of the teeth. So let's have a look at situations where you can clearly diagnose the gummy smile, but you will probably not be able to correct it all, because if you correct it all, you will create secondary problems, such as this young lady that presented. Professor Akram, I'm hearing some noises. Is there something wrong that I'm doing, or is everything okay?
No, it's fine. I'll handle it.
Okay, thank you. So, as this young girl that presented a very clear gummy smile, and you can see that her crown sizes were adequate with no free gingival margins, she had an increased upper incisor exposure at rest, which should be approximately from 2 to 4 millimeters. And it is exactly this amount of upper incisor exposure at rest that will allow you to intrude this maxilla. So she needs much more than 4 millimeters of intrusion to fully correct her gummy smile. And you can understand here that we cannot be able to fully correct it. Otherwise, we would decrease the normal amount of upper incisor exposure at rest. So we really have a trap here where sometimes we can clearly diagnose that in this case, we have a skeletal issue, which would improve the face, would improve the smile, but would create an issue with tooth position regarding rest posture. So us orthodontists, we are trained to look at our patients from a very broad panorama. We look at our patients skeletally, we look at our patients occlusally, we look at our patients also aesthetically, from what we call a macro aesthetics to a mini aesthetics to the micro aesthetics. So I really believe that the orthodontists, they have a very significant role in diagnosing the etiological factors of the gummy smile, and should therefore be the professionals that should adequately diagnose this in an interdisciplinary setting. But in most situations, orthodontics alone is not capable of completely correcting the gummy smile. We will, in most cases, need interdisciplinary treatment. So in a myriad of patients such as this one, we will be able only to treat the minority of these patients with orthodontic treatment alone, correct the gummy smile that I'm talking about. It's a very small portion. Let's have a look at the fact that diagnosing and treating these gummy smile patients is necessary, an individualized treatment plan. It's not easy to treat the gummy smile. It's not an easy task. Every multifactorial issue in orthodontics or in any medical area is not easy. We don't have a recipe to correct these patients. Diagnosis is individual. And we have to have success to be able to organize this diagnostic information. How can we do this? We have to think on the etiological factors, but we cannot disrupt what is adequate for the patient. Therefore, we need a protocol. It was only in 1992 that Peck published a paper establishing the fact that the gummy smile is multifactorial. And they associated this gummy smile either to vertical maxillary excess, to the muscular ability to raise the upper lip significantly higher, overjet, greater interlabial gap at rest, crown height, mandibular plane angle, and palatal plane angle. This was the first time in the orthodontic literature that the gummy smile was associated to a multifactorial possibility. And this was so important that Robert Isaacson, at the time, that was the editor-in-chief for the Angle Orthodontist, said that this article would make a definitive contribution to the progress of orthodontics and would open up a really new field of treatment, which would include limb function on the gingival smile. So what we really need to diagnose and to create a protocol or a treatment plan is a checklist. And this was proposed by Dr. Seixas and collaborators published in 2011 in the Dental Press Journal of Orthodontics. And once again, you can take a picture of this QR code and you will be able to download this paper for free and also in the English language. Can someone just give me the feedback if the QR code is working? Please.
Everything is okay, Doctor.
Yes, it's working.
Okay,
QR
thank
code
you.
is working.
So this is a checklist graphically, and she included 5 aspects that should be looked at during the evaluation of excessive gingival display or gummy smile patients, which were interlabial gap at rest, upper incisor exposure at rest, the smile arc, the width-length ratio of the upper incisors, and the morphofunctional features of the upper lip. Let's have a look at each one of these situations one by one. So interlabial gap at rest. The interlabial gap is the largest distance between the upper and the lower lip when they are at rest, and they should measure from 1 to 3 millimeters. You already can imagine that the only way we can change this interlabial gap is either by removing tooth tissues or either by a surgical approach. So an increased interlabial gap can happen due to an excessive vertical maxillary excess. It's as if the bones were too long for the soft tissues to cover them. Or in the second situation where you have a short lip. But what we have to remember is that despite having an adequate interlabial gap, this does not guarantee that you will not have a gummy smile, since once again, it's dependent on more than one factor. So an increased interlabial gap has no direct interrelationship with the presence or the existence of the gummy smile and the amount of interlabial gap at rest. The second issue, and maybe the most important issue that we are going to talk about in this presentation, is the upper incisor display at rest. The normal display of upper incisors at rest is from 2 to 4.5 millimeters in women and 1 to 3 millimeters in men. And the way you diagnose this upper incisor display is either by a video of patients doing speaking some certain syllables such as Emma, or on cephalometric radiographs. So the ideal display will depend obviously on the gender and on age, but remember 1 to 3 millimeters in males and 2 to 4.5 millimeters in females. And this is something that gives you a youthful look or a youthful aesthetics. And it will determine the possibility or the amount of vertical movement you will be able to do of either the maxilla surgically or of the teeth orthodontically. So this is a key diagnostic factor on the possibilities of correction of the gingival smile. So patients such as this young girl that did not present a gummy smile, but nevertheless presented a deep bite, had no upper incisor display despite being young. So when we think about the correction of the deep bite, we would never be able to approach the correction of the deep bite by intrusion of upper incisors. On the other hand, we will have to think on intrusion of the lower incisors to a point which would allow us extrusion of upper incisors and guarantee to this young girl a youthful speech and a youthful situation of incisors at rest. So patients such as this lady, which also presented very little amount of upper incisor display at rest, you would not think about the vertical intrusion of either the teeth or the maxilla. You would have to think on other methods to correct the gummy smile. So the magnitude of the planned dental skeletal alterations should not be based on the amount of gingival display to be reduced. Otherwise, it should be accounted for on the amount of incisor display at rest that you wish to maintain. In other words, you can only intrude teeth or the maxilla if you have an excessive display of upper incisors at rest. So this is the biggest trap that we have in the correction of the gummy smile. So patients such as this little girl that presented a gummy smile clearly during her clinical evaluation, when we evaluated the cephalometric radiograph and also the posing aspect of her lips at rest, you could see that she had 4.5 millimeters of upper incisor exposure. We know that the range is from 2 to 4, so we had about 2 millimeters of possibility of intrusion to correct this gummy smile, which was not a very large gummy smile, and just the orthodontic intrusion allowed us to create an improved situation of upper incisor display at rest and an improved situation of her gummy smile. So you can compare here, beginning and end. And her smile, just by orthodontic intrusion. But do remember that this was allowed because she had excessive upper incisor display at rest. Nowadays, with skeletal anchorage, I see a lot of these corrections, placing tags on the anterior region to intrude upper incisors. So patients such as this one that already had a normal upper incisor relation at rest, with the intrusion using tags, obviously improved her gummy smile, but gained a very old-looking situation during speech and during rest with no exposure of her upper incisors whatsoever. The smile arc is an interesting feature. It's not associated to the etiology of the gummy smile, and it's described by the curvature formed by the borders of the upper incisors, which should be consonant to the lower lip. But it can be presented clinically as a pleasant curve, as a flat curve, and a reverse curve. And this reverse curve is considered also a very aging aesthetic factor. So patients which already present a flat curve, we should never think about intruding incisors, since we will transform this curve into a reverse curve. Patients with an excessive smile curve, these are the patients which will easily allow and improve their smile line with orthodontic intrusion. The width ratio of the upper incisors should have a proportion in which the width of the upper incisors represents 70% of its length in general. So when we face disproportions of teeth, we can think about the amount of gingiva that we have, as well as the amount of passive eruption that these teeth may have performed due to incisal grinding. So patients with these situations should be probed and can be, in this case, can receive orthodontic intrusion for future restorations due to compensatory dental alveolar extrusion and the which was consequence of the natural grinding of these incisal borders, or just a gingival procedure because you have excessive free gingiva in this situation, characterized by gingival hyperplasia, or yet in something we see in young patients called altered passive eruption, in which these crowns were never really completely uncovered from gingival tissue, and you have an enormous amount of free gingiva, and you can guarantee this patient adequate tooth proportion by performing periodontal surgery. And finally, the morphofunctional features of the upper lip. These should be also regarded, and you already learned how to measure them through a line passing by on the nasal base and 3 perpendicular lines from the commissures to the center of the philtrum. And this should measure from 24 millimeters for females and 20 millimeters for males. So the height of the sulcus and the lip commissures are important. And here you have a long lip, here you have a short lip, and this can have an impact on the amount of coverage that you will have regarding the gummy smile. But please do not forget that even long lips can be excessively contracted and allow for gingival display. Individuals with gummy smile have a more efficient elevator upper lip musculature. So patients such as this one, where she has adequate facial proportions and adequate tooth proportions, has a good excessive amount of gingival display, due most probably to the amount of contraction of this upper lip, but also due to the fact that she has a short upper lip, which is quite difficult to approach. On the other hand, patients such as this one that had a very long upper lip, nevertheless had an excessive amount of muscular contraction, which exposed the gingiva. So it is really important for us to have static, but as well dynamic records of the smile and the speech. So there are specific phonetic aspects that you can ask the patients to perform. We had the phonetic aspects already translated into Portuguese. David Sava has the literature on this, and you can probably do the same, translate these syllables or the phonetics of this into Arabic, which will be quite useful to diagnose the amount of gingival exposure during speech and smile. And finally, we have to remember that the dental-alveolar protrusion will affect the position of the lips through hypermobility. So patients with a large amount of upper incisor protrusion will have this ramp where the lips sort of encroaches on the upper incisors. This was shown that patients that have retraction due to extractions, that the interlabial gap closes vertically at a ratio of approximately 1 millimeter for each 2 millimeters of horizontal retraction of the upper incisors, in which neither extrusion or intrusion has occurred. So patients such as this one with an excessive bimaxillary protrusion, you can see this little fold on the upper arch, on the upper lip. This is characteristic of these patients with this excessive bimaxillary protrusion. Once they are treated with orthodontic retraction, has less gingival exposure because the lip doesn't retract so much when it is being contracted. This creates an improved situation for the smile without any vertical movement of these teeth. This was seen for the first time and published by these Brazilian orthodontists. Dr. Ferreira is a periodontologist and Dr. Brandão an orthodontist. And Dr. Ferreira, when he was operating his periodontal patients for implants, and he had to place these implants on very bimaxillary protrusive patients, he saw that the patients lacked bone, and sometimes the implants could be seen on this upper pyramidal area of the maxilla. And when he placed bone grafting to cover these implants, he saw that there was very little contraction or a reduced contraction of the upper lip and therefore less gingival exposure. So patients, as this one described in this paper, with an enormous excessive display of her gingiva, had grafts placed on these lacunae due to the protrusion of the teeth and the maxilla. And you can see here that it sort of stops the lip from contracting and exposing the gingiva. So you can use this paper also from the Dental Press Journal of Orthodontists as a guideline for your gummy smile evaluation. And a trick here is to place cotton rolls on these depressions so you can see how it will affect the contraction of the upper lip. So let's have a look at some clinical cases with the idea of being those that you could treat only using orthodontics. So these are cases in which you will either intrude incisors or you will either retract incisors. So this young lady had been treated orthodontically before. She presented a bi-maxillary protrusion with some deficiency of her chin and some vertical excess of her lower facial height. She had an excessive exposure in the anterior region and did not want to be approached surgically. She was a class 2-ish on the right side and a class 1 on her left side with an excessive smile curve, as you can see here, and a deep bite. When we looked at her upper incisor exposure, it was quite large. So let's have a look at the checklist. Interlabial gap increased. Upper incisor exposure at rest increased. So this gives me the orientation that I am allowed to intrude either the maxilla or the incisors or both. The smile curve increased, which also allows me to intrude incisors. Proportions of teeth were adequate, and her lip was hypermobile. So understanding that I am allowed to intrude incisors because the upper incisor exposure at rest is increased, we approached the skull with a premolar extraction approach since she had quite a lot of protrusion and did not want to be submitted to orthodontic surgery. We did some intrusion in the upper arch and we had skeletal anchorage here, so we would not extrude these molars and worsen her lower anterior facial height. Distalization of canines and of the lower arch associated to this skeletal anchorage. And finally, the case was finished with a significant improvement of her smile line and obviously of her facial profile, since we approached this with maximum retraction of her upper incisors with skeletal anchorage. So you can see here the dental alveolar changes on the cephalometric radiograph, the changes on her facial profile where she gained passive lip seal, and the changes on gingival exposure with a more adequate smile line. When we compare the smile, the broadness of the smile, you can see clearly that she is with a passive smile, with a spontaneous smile, and changes were really due to the dental alveolar changes, most especially due to the amount of intrusion that we were allowed to do since she had 10 millimeters of upper incisor exposure at rest, and this was reduced by half to about 5 millimeters. And here she is with a very good smile in her regular social life. And the other situation in which we can clinically approach these patients just by using orthodontics is in bi-maxillary protrusions. So you can see this young lady. She presented also a vertical excess with an increased lower anterior facial height, difficulty in doing passive lip seal with a lot of muscular contraction of perioral muscular contraction. And you can see her exposed smile and her spontaneous smile, where you can see the excessive amount of gingival display. She had an excessive amount of smile curve, and we would say that she had almost a indication for orthodontic surgery, but this patient also refused to be treated surgically. She was a class 1 bi-maxillary protrusion and was analyzed with our checklist. So interlabial gap, we can consider that it was increased. The upper incisor exposure at rest also increased, so this gives us permission to intrude incisors or the maxilla. She had a pleasant smile curve, adequate tooth proportion, and a short and hypermobile lip. So when we look at her bimaxillary protrusion, once again, you can look at that ramp, which holds back the upper lip. She was treated with the extraction of 4 first premolars and just regular retraction, some intrusion of the upper incisors to create better proportion of these teeth. And here she is at the end of orthodontic treatment with the reducal of this concavity on the anterior maxillary area. You can see that the ramp also has a smaller degree now, and she has passive lip seal due to the retraction of the incisors, a significant improvement on the facial profile, and a significant improvement on exposure of gingival exposure. And you can see here this girl a long time, and with the broadness of the smile being the same, you can see that the amount of lip contraction, look at that little fold that I pointed out to you. She doesn't have it any longer. It doesn't encroach behind the maxilla. Here she is in 2009 when she finished her orthodontic treatment, and here she is 8 years later, and you can see that she is holding well her occlusion as well as the same amount of gingival display with adequate incisor display at rest, a perfect smile line. And this is something we also have to think about. You can see that this patient had some gingival exposure of about 2 millimeters. We know that with time, we have some loosening of her flaccidity of our musculature. So in broad gummy smiles, we should leave a little bit of gingival exposure, since these patients will age and the amount of gingival exposure will decrease with time. So we understand clearly nowadays that we have different etiological factors for the gummy smile that not usually presents as one single factor, and we will have multiple intervention sites which not necessarily will be associated to the etiological factor. And this last factor, the muscular activity, is something that has been approached more recently through temporary muscular paralysis using the toxin, botulinic toxin. I don't do any of those approaches. I refer these patients to the dermatologist, but this is a possibility when we are not allowed to intrude teeth, and patients will refuse any other treatment approach, such as premolar extractions. So we have to keep in mind that the approach to the gummy smile will generally include more than one tissue, and that it is a multifactorial problem, and that orthodontic treatment alone will treat a minority of cases in which we can include only those that can accept incisor intrusion and or incisor retrusion. The upper incisor exposure at rest or upper incisor display at rest is generally of 2 millimeters and is a key diagnostic feature to determine the possibility of incisor or maxillary intrusion. And when upper incisor exposure at rest does not allow us to intrude, muscular control can be performed by partial paralysis using botulinic toxin or Botox. So I would like to thank you all for your kind attention. I hope I have contributed to with some new insight on the treatment of the gummy smile. These are my contacts, email and social media. Feel free to contact me and to approach me in anything you need. And here is my kind invitation for 2025. We will be hosting the 10th IOC, which is the International Orthodontic Congress of the World Federation of Orthodontics, and I hope to see members of the the Society of Orthodontics of Iraqi over here in Brazil. The 9th IOC is still being held in Japan. It was an online meeting, a virtual meeting on demand. So for those who are interested in watching this meeting, it is still online until November 3rd. You can look it up at the FFO site.